one of the complicating factors is, let's assume lisocabtagene gets approved, we're going to have 3 different products. We'll probably have 3 different REMS programs, right? We have, up until now, we've had multiple different, criteria for even calling toxicity. The management is different. I mean, we need some consensus. Is there any hope for the future here for consensus?
Well, we've got the SPMT paper, which at least has made the effort of actually coming to a consensus on the grading system. So that is really the right step in the right direction.
I don't believe there's a consensus on therapy.
Well, so there may be one. I think there may be a CARTOX 2.0 that comes to the journal near you.
Not only CARTOX 2.0, but several professional societies, including ASTCT, is working on consensus guidelines, and then the SITC is also working on consensus guidelines to how to treat toxicities with immune effector cell therapies. I think going through those processes, even here at this ASH meeting and having those meetings, it's clear that there's going to be areas where the management differs at different centers and maybe even by the product or the patient, pediatric versus adult, ALL versus lymphoma. But there are some basic tenets that will be out there for people in centers that are new to CAR T-cell therapy to look to.
And then you said we'll have 3 REMS program with the presumed FDA approval of lisocabtagene maraleucel. We're going to have 4, right? Because we're going to see BCMA CARs.
Right, we'll have myeloma. We'll get to that. We'll get to that in a second. But I think the point is that we're seeing more similarities. We're seeing a convergence of therapy. I mean, people at our center anyway, our policy is to try to actually keep people out of the ICU, to treat them before they get so sick that they end up in the ICU. And that wasn't always the plan. And in some of the earlier clinical trials, we treated people and you were afraid to intervene. So I think the more data, we need more data about early intervention. I know there's an early planned steroid use has already been reported a little bit with the axicabtagene ciloleucel, and there are ongoing cohorts that are going to even look at that in an earlier fashion. So I think that's very exciting. But there are other diseases. Karen, you just mentioned that. So, well, what about myeloma? What did you see at this meeting about myeloma?
Well, I mean, I think what we've seen things that have been published preceding this meeting about myeloma. We've seen very, very high, very good PR rates and CR rates and even MRD negative CR rates. The durability historically with the current products seems to be an issue. So, we think the median durability of response or median progression-free survival is around 9 to 11 months, which is a problem for myeloma. And I think that your group presented some data about a way to maybe overcome that. Those relapses.
The CARs that are in the clinic right now, the BB2121 is a murine construct, and so one of the complicating factors is, do the cells persist? Do they get immunologically rejected? Along those lines. So we actually have experience with a humanized CAR, or human CAR, against BCMA, and we have a couple trials with that. But at this meeting, one of the more interesting trials was combination with the gamma secretase inhibitor. Turns out gamma secretase cleaves BCMA off of the cell surface, and it's prevalent in serum, and so you can actually have loss of the BCMA antigen from the surface due to gamma secretase. And if you can block that, the expression of BCMA goes to about 100%. And in an early phase 1/2 trial, we're seeing very encouraging results with high response rates and very few relapses so far. I mean, it's really early. You can't claim too much about it, but I know this was a very well-received abstract at the meeting, and we were very excited about it. And I know that approach has been even considered in some of the other BCMA-directed treatment options.
Yeah, I thought that data was really impressive. It's very early, but to the point of the lack of durability to some of the BCMA CARs and the products that likely we expect will be FDA approved, I think that also becomes an issue when, if they become approved, at what price will they be? Because you have to look at quality-adjusted life years, and if you're not curing the same degree of potentially curing the same degree of patients as we see with lymphoma, then the value of that therapy overall may be less, and we also know that many of these patients are older to begin with. So I think that's something we have to keep our eye on as well.
I think the problem with myeloma is that, at least with non-Hodgkin's lymphoma, we usually have very clear criteria of lines of therapy, whereas multiple myeloma, it is really, we have no clear pathway. What is a third line, a fourth or fifth line patient? Because there's just so many ways how to get to that point. And then to make the exact decision, okay, we're going to take fourth line patient, that is really, I find, a real challenge to actually come up with guidance on that.
Right, so there are some ongoing studies that will hopefully address whether, this lack of durability of response may be an issue of lines of therapy.
Right.
So there are some of these randomized studies that are starting to
Sure.
take patients and
line.
randomize them in different lines of therapy, and that will hopefully answer that question.
I mean, obviously, consolidative CARs. I mean, what if we stop doing autos? What if we use consolidative CARs? I mean, I think the BB2121 trial, what was the median lines of therapy was 7 or 8 or 9? I mean, it was really
Really very
a
high.
huge number. And so you don't know what that mutational burden is from all that prior therapy by multiple auto transplants are going to be in terms of the risk of relapse. So I think, I think the future, I've never seen anything work better in terms of massive myeloma in terms of inducing a complete remission.
Although I really do see that BCMA targeted therapy is not just CARs, it's also bispecifics, and there's been some very exciting data being presented at previous ASH meetings and this one too, and showing very similar response rates and duration of response being in a similar range, particularly with the BiTE construct by last ASH that we presented. So it's not quite clear how this is going to be sequenced in that context. And also looking at the toxicity profile that you may get with the bispecifics, this might be even more favorable than doing a CAR logistically by far. This is an off-the-shelf product. So we just have to see how that will work.
We've also seen other diseases, just mantle cell. Do you want to just mention mantle cell?
Yeah, so we had discussed this briefly before, but the response rate in mantle cell is even a little bit higher than it is in diffuse large B-cell lymphoma. It's over 80%, and the CR rate is higher, so it's over 60% in mantle cell lymphoma. And of course, this is an early study with limited follow-up at this point, but these responses appear to be durable, and they're durable in the highest risk mantle cell lymphoma groups. They're durable in TP53 mutant mantle cell lymphoma. They're durable in blastoid and pleomorphic variants. They're durable in patients that have complex karyotype, and so I think that we're at a time now where patients are now progressing through BTK inhibitors because we know the median duration of response in those drugs is only about 1.5 years, and they're saying what next? And I think we're going to be able to offer those patients something.